all interventions have their place.
Yeah.
Like, it is fantastic we have these interventions when there's a clinical need, but actually intervening in a healthy pregnancy with a healthy baby without a clinical need, we know we cause a lot of problems for moms and babies.
Hello everyone and welcome back to No Place Like Home. I am joined today by Rachel, whose background is in private midwifery. We have just done a podcast previously to this where we've met you properly, Rachel. So if you haven't listened to this prior to this episode, tune on in.
Mm-hmm.
We've got an interesting little topic to talk about today.
Yeah.
So we're going to be unpacking acronyms, sort of common obstetric terms and abbreviations that buzz around, I guess.
Yeah.
This has sort of come about, we're 90-odd episodes in now, and certainly I've worked in the medical field for a long time, but obstetrics is so specialised. There are so many things I have no clue about, and I'm sort of integrated in health from a perspective of, you know, being a patient sitting there in front of, you know, this is brand new pregnancy, not done this before.
Yeah.
We sort of thought, let's dig a little bit deeper into some of these common terms and kind of understand the when and the why.
Yeah.
So you're going to help me with that.
I am.
Thanks in advance.
You're very welcome.
We're going to kick off with a couple of terms. I'm going to group them together because that's what we've sort of spoken about it looking like. So they're terms that most people have heard about. Trimester. So we know it's broken up into 3 and that each lasts for about 3 months. EDD or EDB. So talking about the gestation date, like what that looks like. So expected date of delivery or birth.
Yeah.
And then gestational age.
Yeah.
So the when and the why of this,
Yeah.
right?
So everyone will be given what's called a due date, which doesn't mean a lot in itself. That due date marks your 40 weeks. So at the point you hit 40 weeks gestation of pregnancy. It doesn't mean you'll give birth on that date. It doesn't mean you'll give birth by that date. Women are term between 37 to 42 weeks of pregnancy. So that means there's a 5-week period where it's a normal time to give birth. Really, we should have a due date at 42 weeks because a lot of people start feeling pressure and get a bit stressed when they get to that 40-week mark. But the reality is for first-time mums, if we don't interfere, then the average time to give birth is about 41 weeks. And there are countries that do give a due date at 41 weeks because it is a bit of a better average.
Isn't that crazy? We are obsessed with dates around, you know, this pregnancy and postpartum period and what that looks and feels like. But when we know the average, that feels a bit nicer.
Yeah. And I think if we had that 42-week date, it means that anything before that is just a bonus and women are not feeling that pressure. But we calculate the dates from the first day of the last period. So the first 2 weeks of pregnancy, you're actually not pregnant at all. So you would conceive in that kind of second week of pregnancy. So really, pregnancies, we work it out about 38 weeks from that time of conception. So it's why if women know the ovulation dates, conception dates, that's a bit more of a more accurate way of working out that due date because everyone's cycles are a little bit different in length. And scans can give us an idea of the due date early on, but scans are only accurate to within a week either side of the actual date. So we try and get as accurate a date as possible so that women aren't being offered things like induction kind of too early.
Yeah.
And then you're absolutely right. Pregnancy is split into 3 trimesters of about 3 months each. We generally classify the first one as about the first 12 weeks or so, and then the third trimester is from about 28 weeks onwards. So the second trimester ends up being a little bit longer, but roughly at that 3 months each.
So why is it important to break them down into trimesters? What's important about that?
So It's probably we see more classic things within each of those trimesters, and everyone's a little bit different, but that first trimester is generally where we see a lot of the early pregnancy symptoms. So in that first trimester, it is the hormones that are responsible for growing this baby and getting everything to this baby that it needs, and the placenta is still forming and developing. Once that placenta is fully formed, which is about 16 weeks of pregnancy, that takes over that function of getting everything to and from baby, and it means the hormones kind of settle down a little bit and level out, and that's why people suddenly start feeling a lot better most of the time. Unfortunately, there's some exceptions to that, but the majority of women suddenly feel a lot better through that second trimester. And then third trimester, we generally have just more things associated with the size of baby coming up, or more of that pelvic instability, aches, pains, things kind of coming up. Yeah. But yeah, there's not a huge amount of relevance to the trimesters themselves, but I think having a really accurate kind of date, so we know kind of the gestation that woman is at as accurately as possible, is a good thing to have. And understanding that due date, only about 3 to 5% of women actually give birth on their due date. So we're not expecting anything to happen at that point.
It's so important to know that. In knowing this in hindsight is a really wonderful thing. I wish I could inject that knowledge into my past self. So let's talk about gravida and parity.
Yeah.
So gravida being the medical term that refers to the pregnant woman or number of times that that woman has been pregnant.
Yeah.
Obviously, that varies between women.
Yeah.
And then parity is the number of children that woman has carried.
Yeah.
Up to 20 weeks?
For at least 20 weeks
at least 20
of pregnancy.
Weeks.
Yeah.
Okay.
So we'll often write in women's notes something like G2P1, which would mean it's that woman's second pregnancy and she has one child that she's carried beyond 20 weeks. So the gravida is just the number of pregnancies that woman has had. That would include any early miscarriages she's had. Any time she's been pregnant, we would put that in the gravida.
Yeah.
And then the parity is how many children she has carried beyond 20 weeks.
Why is that important to know for you as a healthcare professional in your field?
Yeah. So it is important. It's important for a lot of different reasons. So that gravida, it's important for us to understand why she's had those pregnancy losses, what reasons there are for that, for us to support her from a medical perspective if there have been fertility issues, also to support her from a social, emotional perspective with any losses that she might have had. And then the parity, again, that informs a lot of things. Like a first-time mom will generally birth very differently to a second-time mom. You'll often hear us refer to terms of primip and multip. So a primip is a primiparis woman. So primip is someone who is giving birth to their first baby, having their first baby. Yeah. And a multip is someone that is having their, second plus baby, so any subsequent babies. And, typically we're expecting primips to have quite long labours. Primip labours are generally the marathons. And then if you have a vaginal birth first time round, generally you'll go on to have much quicker births after that. So it means quite a lot for us as midwives as to what number birth that woman's on.
Yeah, okay.
We also know if she's had a significant number of babies, then a few risks start increasing. So we're just a little bit more aware of those risks of things like hemorrhage kind of after the birth.
Yeah. So essential to kind of get a fairly good idea about their journey, right? Like before they arrive.
Yeah.
Yeah. Amazing. Fundus.
Yep.
So, what is it? What is it, Rachel?
So the fundus is the top of the uterus. So you'll often hear midwives talking about feeling for the fundus, whether feeling your tummy or measuring a fundal height with a tape measure. That's one of the ways we keep an eye on the growth of baby.
Yep.
So up until about 24 weeks, we know about where we expect that fundus to be. For example, we expect it to hit the belly button about 20 weeks of pregnancy. So we're just feeling that it's roughly at the right point for the gestation the woman is at. From about 24 weeks onwards, we start measuring with a tape measure. So we measure from the fundus, that top of the uterus, down to the pubic bone. And a woman should measure roughly in line with how many weeks pregnant she is. So at 28 weeks of pregnancy, we're expecting about 28 centimetres on a measurement, a couple of centimetres either side. And we're just making sure women grow proportionally kind of between appointments. The fundus is also relevant postpartum as well, because we check that fundus kind of through the first kind of week or two after a woman has a baby. After birth, we expect it to be sitting about the level of the belly button or below. And then every day we expect it to do what we call involute, which is get a little bit smaller and more contracted each day. And then about 10 days up to 2 weeks after the birth, that uterus should slip back behind the pubic bone so we can't feel it anymore.
Great. So as far as actual growth in, like, it's important to know about the fundus for growth of barb, and does it indicate for you as well the health of pregnancy, or not necessarily?
It's more just to check on that growth of babies. So there's a few ways we do that. Like, the measurement is just one aspect of it. But, you know, midwives have a lot of other skills and techniques that they're learning. A big one is just palpation, which is feeling that uterus, because a measurement with a tape measure only tells us one thing. But that measurement can be affected by how high or low baby is in the pelvis, how much fluid is around baby, what position baby is sitting in the uterus. So those skills of palpation are really important in knowing what we're feeling for. We know roughly how big we expect baby to feel kind of beneath our hands. And that is the recommended way to be monitoring a baby's growth. Scans are getting more and more common, but growth scans are notoriously inaccurate. And they get less and less accurate the further on into a pregnancy you go. So by the time you get to the end of pregnancy, they're really not worth doing for growth, because it's really hard to get an accurate growth measurement.
While we're talking about growth, there's obviously some terms that sit around that as well. So IUGR or FGR or SGA. So they're all talking about growth restriction, growth of baby. When are people hearing about this? And is this something that you're talking about with every pregnancy?
So IUGR stands for intrauterine growth restriction. And that is something that we would be concerned about if we suspected that, because it's generally a sign that the placenta isn't functioning as well as we would want it to, and baby isn't thriving. So what we typically see with IUGR is the growth slowing up. So it might be a baby's growth that started on a really normal centile and then just keeps dropping and dropping the centiles. We also start seeing this disproportionate growth. We often see a more normal kind of head circumference measurement, but we often see that the abdominal circumference really starts to drop off, because babies, they're not able to kind of grow all that good body fat. They're really, any energy they are getting, they're using it to growing important things like the brain, and not so much rebuilding up those fat reserves. So a baby that has true IUGR is a baby we're concerned about, because those babies are going to be at a higher risk of stillbirth. There is also a term called small for gestational age, which is SGA. And this more refers to a baby who is on a lower centile but tracks along that centile quite nicely. So a baby that is growing proportionally, and that head tummy measurement are kind of in proportion to each other. And generally those babies are just genetically smaller, and that is normal for them. But we just keep an eye to make sure that they're not falling off those centiles and tracking down. But one of the best ways we can check on a baby's well-being if we are suspecting if there's any growth restriction is to check the fluid levels around baby. So do what we call get an AFI measurement, which is the amniotic fluid index. So that amniotic fluid is the fluid that's around baby. And if that level drops quite low, it can be a sign that baby's kidneys aren't functioning as well, because that fluid is just baby's urine. So baby's constantly swallowing that fluid and peeing it out in the womb. It's a constant cycle. That is a beautiful image, isn't it?
It is delightful. So is the best way to do that through scan?
Yeah, so to assess the fluid level, we can get an idea palpating a woman's tummy, but a scan is going to be a better way at assessing that fluid. And the other thing a scan can do is check what we call the Dopplers, which is a flow of blood through the cord. So that can tell us how well that blood is getting to and from baby. Yeah. And those things, I hold a bit more importance to those than the actual growth aspect of the scan. Yeah.
So you could do a lot from palpating, as you've said, and feeling and knowing what is going on. But the relevance of a scan comes in when you need just to get that injection of information.
Yeah, absolutely. If we're concerned about a baby, then it's always worth doing a well-being scan, which would be checking fluid and that cord flow. And growth, if we're concerned, we definitely do growth scans if we're concerned about the growth based on measurements and palpation.
Sure.
It's just doing a growth scan on women who don't necessarily need one. Yeah. We know we're then massively increasing the risk of then women being induced for a supposedly either big or small baby, when the majority of the time those babies are born a really normal size. And even if they are born bigger or small, it doesn't necessarily mean that there would have been any problem waiting or having a natural birth.
And potentially even just that induction of fear, like, you know, okay, there's something wrong. We need to, you know, interact more heavily with you know, whatever that looks like, whether it be, like you say, induction or other induction methods.
Yeah. We know we cause a whole load of other issues when we do a lot of unnecessary interventions. So, like, all interventions have their place. Yeah. Like, it is fantastic we have these interventions when there's a clinical need, but actually intervening in a healthy pregnancy with a healthy baby without a clinical need, we know we cause a lot of problems for mums and babies doing that. There's a lot of risk to doing that. So we want to make sure we're reserving things like induction for when it's needed.
Amazing. So we'll move on to GDM or the glucose, in line with that, the glucose tolerance test. So gestational diabetes mellitus, which is, you know, we hear this term a lot and we test everybody for it now. Anyone who gets pregnant, come and have the drink. We'll have a chat.
Exactly.
So obviously this term is thrown around quite a lot. Talk to me about the when and the why of this.
Yeah. So Australia, as you said, does offer the testing to all women. I would never say all women have to do the test. I hate any term like that. Everything is always optional to a woman. But the glucose tolerance test is a diagnostic test we have for it. So that's the only way we can say definitely, you know, yes or no, there is gestational diabetes present. So gestational diabetes is diabetes that appears in pregnancy and it goes away after baby is born. A lot of places around the world don't test everybody. They usually do it more on a risk factor base. So if someone has risk factors for gestational diabetes, we would offer the test, but Australia does offer it to everybody. So it's a 2-hour test, involves 3 blood tests over the 2 hours. We did change the reference ranges a few years ago, and we're now having twice as many people being diagnosed with gestational diabetes.
Problematic in its own. Yeah.
And everywhere uses different reference ranges. You know, you go country to country, but the ones we have in Australia, we're expecting the sugar levels to be extremely low, probably a bit unrealistically low. It's always a bit frustrating if someone kind of just tips into that kind of positive range for gestational diabetes, when the chances are there's actually probably nothing wrong. It does then cause a lot of extra stress. But on the other hand, if someone's got really high sugar levels, it's actually a really important thing that we can pick that up and that we can manage it appropriately. There are a few issues with the glucose tolerance test in that it is a bit of an unnatural way to check the body's response to something, because we get the woman fasting and then we get her drinking a whole load of sugary water all at once. And when in life do we ever really do that?
Oh, it's horrible stuff too. Yeah.
So some women really can show up odd results from that, but then when they're just doing their finger prick testing afterwards, everything's actually really normal. It's just their body's not used to having such a big sugar load on an empty stomach all at once.
Yeah, amazing. Good for us all to know, because it's something that we obviously come across, and like you say, the options there for most of us.
And there are other options for screening for gestational diabetes. So there are tests we use as screening tests and not diagnostic as such, but they give us an idea, things like the HbA1c or doing a fasting glucose. Like that can give us an idea if there's diabetes present. Or some women just prefer to prick their finger for a couple of weeks and just keep an eye on the sugars that way. And if all is normal, then we'd say there's no diabetes present.
Yeah. Great. So let's talk about position of the baby. There's obviously a lot of different positions that the baby can fall into.
Yep.
Cephalic, posterior, transverse, breech, full in breech.
Yep.
Why? I mean, we can talk about what each of them are, but what I really want to know is, when are these an issue?
Yeah. So in an ideal world, we want a cephalic baby. So cephalic means head down into the pelvis. Sometimes you'll hear the word vertex, but essentially a head in the pelvis is what we're looking for. We know that is the most common way for a baby to be born, and it is the safest way for a baby to be born. Cephalic babies can sit in different positions in relation to where their back is sitting within the pelvis, though, which is something that we feel for through the third trimester. So each time we're palpating someone's tummy, we're feeling for that position of baby. So a baby can essentially be in an anterior position, transverse, or posterior, and that just means whether they have their back towards the front, the side, or towards the woman's back, which should be like a spine-to-spine position. Generally, an anterior position is the easiest position for babies to come down into the pelvis and be born in, because babies can tuck their chins in really well, so they flex their heads, and that small diameter at the back of the head is the part that's going to come down first. When babies go posterior, they generally deflex their heads, so they lift up their chins, and then you've got a wider diameter at the top of the head that starts to come through. So
a bit harder to get out.
A little bit harder. Not impossible. Babies can certainly be born in a posterior position, but a lot of babies that start off labour posterior, a lot of them do rotate during labour. The few that don't, they can be born posterior, but generally it does create for a bit of a longer labour. But I do think we've got to be mindful of saying that all babies need to be in an anterior position, because everyone's pelvic shape is a little bit different and everybody has different tightness of their muscles and fascia and ligaments through their pelvis. So some babies actually do just sit a bit better in a posterior position. So I don't want women to be scared of a posterior baby. But if we pick that up, we're just going to be getting a woman just to do different positional things at home, just to encourage baby to come round to the front if that's right for that baby, just to give that baby that option to do that. But I would never want a woman to be stressed about which side baby's back is lying on.
Sure.
And then breech.
Yeah, breech is a bit of a term that, people fear.
Yeah. So breech is where we've got a baby coming bottom first. If we've got a bottom that's fully sitting down in the pelvis, engaged in the pelvis, and that's a pretty good position as far as breech goes, because the bottom is a similar diameter to the head. So we want something to be fully filling that pelvis, because we would be concerned about something like a cord prolapse happening if we had, say, a foot or a knee coming down first. But if we've got a bottom kind of plugging that pelvis, then most women can have a vaginal breech birth, but we know that option is very limited to them because there are so few practitioners now who will support it and who are experienced in doing breech birth. And the experience of the practitioner is everything. If you want to have a breech birth, and in Australia, a lot of practitioners have lost that competency, which is a really big shame, because stats show the risk to a baby being born breech is not actually significantly higher than a baby coming head first. It's slightly higher, but it's not as much higher as what is often made out to women. A lot of women are told it's really dangerous to have a vaginal breech birth. But I think all women should have the option and should be able to make an informed choice and have access to good evidence to make that choice.
So we've got a couple of terms that are kind of quite straightforward coming up next. They're good terms for people to know. They would have absolutely heard them, no doubt. So cervix, the show, and VBAC. Yeah.
So the cervix is the sphincter at the entrance to your uterus. So essentially you've got the uterus, which is kind of a big kind of ball of muscle.
Yep.
And then the sphincter is that kind of opening to it. And then beyond that sphincter, you then have the vagina. So that sphincter, when a woman's not in labour, that sphincter should be tightly closed and it should be quite long. It's usually about 4 centimetres long.
Yep.
What then happens in labour is that cervix has to thin all the way down to becoming paper thin, and then it has to open up to about 10 centimetres dilated, which is the diameter of a baby's head, so baby can then pass out of the uterus and into the vagina. But I think it's a good one to talk about because a lot of people are actually not that sure what a cervix is. A lot of people think it's their vagina that has to dilate and open. It's not the vagina.
Yep.
It's that sphincter that's opening up. And only when that has opened up, the baby's head can slip past it, can baby then start coming down into the vagina.
Yeah.
Great. And the show that you mentioned is kind of mucus, like quite kind of thick, sticky mucus that sits within that cervix. So often little bits of it will start coming away in the lead up to labour. Usually it's just like white coloured mucus initially. In early labour it might start being more like pink or brown mucus. And then in kind of active labour we generally see more of the bloody shows where you still get that mucus but you have streaks of like red blood coming away with it.
Yeah. And then VBAC is obviously... Lots of people have heard the term vaginal birth after cesarean.
Yeah. Every woman that's had a previous cesarean, or most women that have had a previous cesarean, should have the option of having a VBAC. There's very few kind of real contraindications to it. We know that the chances of a successful VBAC are exactly the same as a woman's chances of having a successful first birth. So it's something we would definitely encourage women to do. We know that overall there are small risks associated with a VBAC, but we know that on balance the risks of having an elective cesarean are actually greater than the risks of having a VBAC, which is why most women generally would be encouraged to have a VBAC. And we know that the further they got in their first birth that led to the cesarean, we know that just increases their chances even further of having that successful VBAC. But there's a lot of things we look at. We'd always look at exactly like the circumstances of that first birth, what happened, what led up to the cesarean, what type of cesarean was done, just making sure that it was done in a way that is appropriate for that woman to have a VBAC. You can also see terms written around like VBAC, but VBAC after 2 cesareans. So like VBA2C, for someone that's had 2 cesareans and then has a vaginal birth, which the risk going from 1 to 2 cesareans and then having a VBAC, there's not actually that much difference in the risk. A lot of people think they can have a VBAC after 1 Caesar, but not after 2, whereas the reality is the risk doesn't change that much. The other term that gets bounced around is HBAC, which is home birth after cesarean.
Wow. Obviously, there are different risks that sit around that, which we don't need to go into today, but good to know that that's something that can be done as well. Yeah. Let's talk about epidural.
Yes. Oh, big topic.
Taboo. So we know that it's a form of anaesthesia that can be given during labour.
Yeah.
We know that it goes into the spine. And it its intention is to stop the pain. There are varying levels of that.
Yeah.
So when and why? Like, why are we hearing this? Probably is the reason. Yeah.
So with an epidural, a little tube is kind of put into the epidural space, kind of close to the spinal cord in the back. So a needle's put in first and a little tube is threaded in and the needle's taken out. And then there's medication that's then continuously dripped down kind of into that space. It's anaesthetic type medication. And the aim of an epidural, as you said, is to make the woman fairly numb from the waist down with various success. I do always let women know if they're wanting an epidural, there's actually no guarantee that they're going to get the effect from it that they're wanting. There is that 20% chance that it isn't going to give that desired effect. They might get a partial effect from it or they might get no effect from it at all. It certainly is the most effective form of pain relief. Like, that is the pro of it. And they do have their place, epidurals, but they do also come with a lot of risks. So I'll support a woman with anything in birth as long as she's making an informed decision. So I would always kind of have a good conversation about the potential impacts that an epidural would have on her labour. We know that epidurals increase the chances of babies becoming distressed, so that then increases the chances of having an emergency Caesar. So often we see an epidural go in and a baby's heart rate go down. Babies just don't always tolerate the epidural drug, and sometimes they just don't tolerate the drop in blood pressure that comes with having an epidural put in. The other thing an epidural will do is it will knock off your oxytocin levels. So oxytocin is the birthing hormone. We need high levels of oxytocin during labour to keep labour progressing. Epidurals kind of dampen the effect of that oxytocin. So you'll kind of, probably the longer you have an epidural in, your oxytocin level will drop down. So epidurals do tend to significantly lengthen a labour. And a lot of those women then end up needing a hormone drip to then speed the labour up.
Sure.
And that hormone drip then comes with extra risks for the mum and baby as well. So then you're kind of adding different risks on top of each other. It's also really hard for a baby to come down into the pelvis with an epidural, because when a woman has an epidural, she has to lie on the bed. There's no other option, which means she has to sit on her pelvis, and that compresses the pelvis. So you're narrowing the diameter. If a woman is upright during labour, that pelvic diameter can open quite significantly and make quite a lot of space for baby. And you've then got the effect of gravity, which is then helping baby come down into that pelvis. When you're lying on your back, you've got less space, and then baby's trying to come kind of sideways and then uphill into the pelvis. So it's much harder for them to do that. And you also just don't get any of those pushing urges in the second stage of labour. That would be the other part of it. So it is significantly harder to push out a baby with an epidural, particularly a first baby, because usually the pushing stages of the first baby are long. So there is a much higher chance of needing like a forceps birth or a von-tooth birth. So we call them instrumental births. As well as just risks to the mom. Like, we know epidurals would increase the risk of things like a postpartum hemorrhage afterwards. The woman has to have like a catheter put into a bladder. That increases the risk of urine retention and urine infections. So there's a whole load of things that kind of come for the mom as well. So I think it's important to have those discussions with women, because a lot of people are not aware of that. And the first time an epidural is mentioned to them is in labour, and they're just like, yes, give me anything. I don't want to hear about it. And and those discussions are not often had with her. But I think women have a right to know the reality of what they're accepting.
I think what I know working in this space is lots of people don't know the difference between a spinal anaesthetic and an epidural. And they talk to me as if they're one of the same, which I know to be not true. So the difference between them, just so that everybody knows and understands, and the place of them. So a spinal anaesthetic would only be used if you were having a cesarean. So it wouldn't be used through labour. So there is a slight difference in where they're placed. So a spinal, it's done as an injection, so you don't have that tube put into the back. It's just an injection that puts the anaesthetic directly into the fluid around the spinal cord, and it has quite a quick effect. So usually within 5 minutes or so, the woman gets quite numb, and usually quite densely numb. But it is limiting with how long that effect lasts. So usually after 1 or 2 hours, the effect starts to wear off. Whereas with an epidural, because you've got that tube into the back, you can continuously give more medication through it. So, an epidural will last as long as you need it to last, and you can control it a little bit more with just the exact level of numbness that woman has. A cesarean can be done with an epidural. So if a woman has an epidural already in labour and then the decision is made to then go for a cesarean, we can top up that epidural. So it gives more of that numbness and that density so that we can do a cesarean. But if a woman doesn't have a pre-existing epidural in and goes for a Caesar, then the aim is to put a spinal in. It's much quicker effect and a denser block. Let's talk about prom. And the variations that sit with that, because there's a few. But also just what it is.
So you could hear the term SHROM as another term, which is spontaneous rupture of membranes, and then the term PROM is pre-labor rupture of membranes. That's when the waters break before labor has commenced. And I think a lot of people expect that to be the case in labor. A lot of people have seen the movies and think that their water's just going to explode in the middle of a supermarket and then they're going to have like a mad dash to get to hospital and it's all going to be happening. Whereas the reality is usually not quite like that. About 10% of people will break their waters before labor starts, which means about 90% of people, the waters are going to break in labor. Usually towards the end of labor, we would see it happen. If it happens at all, like those waters don't have to break. Baby can be born in the bag of waters, which is called an on-call birth. And we see it quite a lot doing home births because we don't generally break the waters, but it's quite a rare thing to see in hospital. In an ideal world, those waters would break once the woman is in labor, but we don't have control of that. If they break before labor starts, then the hope is that that woman goes into labor spontaneously. Different hospitals would have different policies and protocols about how long they would typically want to leave a woman before offering an induction.
Sure.
I will stress it always comes down to the woman's choice at the end of the day, but some hospitals, after 24 hours, they want to do an induction, some after 48 hours, some it's 72, some it's as far as 96. We know that there is a potential for infection once those waters have gone, and that risk of infection goes up steadily over the first 4 days. And then after 4 days, so that 96 hours, the risk of infection goes up much more significantly. So the advice is generally to have aimed to have had baby by that 4 days post waters breaking. And we always just keep an eye that the waters are clear or pink in color and that they're not green or brown, which means that baby has had a poo inside.
Yeah. So let's talk about the immediate postpartum period, because there are a couple of terms there. Meconium, we just mentioned it.
Yeah.
So what is that?
Yeah. So meconium is the first poo that baby does. So meconium has been in baby's gut through the pregnancy. So after birth, in the first couple of days, baby will pass a lot of black, sticky, tar-like poo, which is the meconium. And then after that, the milk poo will start coming through. So there'll be a few days of transitional poos where they're a bit greeny-brown in colour. And then it'll be pure milk poo, which is yellow in colour. It's like a mustard yellow. So usually by the end of the first week postpartum, we see those mustard yellow poos. But some babies can pass meconium during the labour or during the pregnancy, which we'd only see once the waters are broken, but that's when we would see what we call meconium liquor. So liquor is the water, that amniotic fluid. If there's meconium in it, it sometimes is just a sign that baby's got a mature bowel. It's a bit more likely to happen the later the gestation they are. But it can be a sign that baby's a bit unhappy about something. So it's something that we would want to get labour happening if it hadn't started already.
Sure. APGAR score. Most people have heard this if they've had a baby. And, you know, there's different levels. There's lots of numbers. Knowing that you're looking at the baby. When is this an issue, or what are we actually looking for when they're looking at the APGAR score?
So we just use it as a tool as midwives. So we give all babies a score at 1 minute of life and at 5 minutes of life. And it's a score out of 10 that they get. So there's 5 different things we look for, and they either get a score of 0, 1 or 2 for each of those 5 things we're looking at. There's nothing we generally need to physically do, particularly with a well baby. We're generally going to be doing more of a visual assessment on that baby. But we are checking things like, you know, the heart rate and their breathing effort and their colour and their tone and reflex response. So they're the things that we're looking for. A baby at 1 minute of age would score a maximum of 9 out of 10 because babies always lose 1 point for colour because all babies are born a bit of a purple colour, which I think is important for women to know. A lot of people are worried thinking that their baby's in trouble when they're born purple, but they're not born pink until once they've activated that pulmonary system and they're breathing and using their lungs, that's when they pink up. So a purple baby is very normal, but it means they will never get a 10 out of 10 score at birth. But we use it just to assess kind of how kind of much support that baby's needing, kind of how good or bad a condition they are born in. So obviously the lower the score they get, the more serious the condition they are in.
Lokia.
Lochia is the postpartum bleeding. So after you have a baby, you can bleed for up to 6 weeks afterwards. So we call that blood the lochia. And generally it starts off quite heavy and quite red. And then that heaviness usually tails down quite quickly. But then the light bleeding tends to just go on for weeks. And it gets really annoying because it kind of ebbs and flows a bit. And women keep thinking they've stopped and then it starts a little bit again. But generally, it can be that red for kind of 1 or 2 weeks, and then it goes more pinky colour, goes a bit brown at the end. Eventually, it just goes into like a white colour and then disappears.
And it's obviously important for health professionals to know what that looks like, but also the birthing person themselves that, okay, that's still there, that's what it looks like, and be interested.
Yeah, absolutely. And we want to make sure that the amount of it is normal. So obviously at birth is when the highest amount of blood loss happens. Everyone loses an amount of blood at birth. So up to 500 mils is normal to lose. Between that 500 to 1,000 mils will be classed as a minor hemorrhage, and over 1,000 mils will be classed as a major hemorrhage. So the midwives are monitoring that at birth. But after that point, we want to make sure that that woman's not losing excessive blood. So we wouldn't expect her to, be filling more than 1 pad an hour, like a whole maternity pad. We expect little clots. We don't expect huge, big clots coming away, and we don't expect the bleeding to be getting heavier. We expect it to just gradually keep easing off.
Sure. Perineum. Let's very briefly chat on that.
Yes. So the perineum is the area between the vagina and the anus. So it's all the muscles and tissues that are involved in that area, and it's the most common place that women would have a tear after birth. So if there's any stitches, usually they're down the perineum and a little bit into the vagina. But it's an area that has a great blood supply, and it usually heals really quickly after birth, and generally will heal a lot quicker after a natural tear compared to an episiotomy.
Mastitis is my last one that I have here.
Yeah.
So it's a great one to end on. Yeah.
This is one I'm very passionate about because I feel like there's a lot of bad advice that's given around mastitis, a lot of misconceptions. Most cases of mastitis are what we call inflammatory mastitis, which means there's actually no infection, there's no bacteria there. But a lot of women with mastitis, they'll go to a GP, and the GP, who it's not their specialty, kind of all their training really around it is to give antibiotics. And we know the majority of the time antibiotics are not needed, so they're not going to help the situation. But it also doesn't get to the root cause of the problem. Inflammatory mastitis can make a woman feel very unwell. It can make her feverish. It can make her have a very fast heart rate. It can make her feel like she's got the flu and shivery and achy and all of that. So a lot of women assume there must be infection there because they're getting those systemic symptoms. But if there's no bacterial infection, antibiotics will not help the situation and will potentially make it worse because it can then cause dysbiosis within the mammary glands. So women with mastitis, I would love for them to know that going to get support from a lactation consultant is probably the best thing that they can do, and get that quick, timely advice and support, because there's a lot we can do to get on top of mastitis really quickly and to address the root causes of it, to try and reduce the chances of it happening again and recurring.
Great. Yeah, it feels like there's a lot of negative talk around mastitis and the must-dos around it. So knowing that it's not a sentence that is horrible, and knowing how to action that's important.
Exactly.
Thank you so much, Rachel.
You're very welcome.
I've found this very informative, and hopefully those of you listening at home have thought the same thing. And just letting us know what these abbreviations were and the when and the why has been incredibly beneficial. So thank you so much for joining us.
It was my pleasure. Thank you.
This podcast represents the opinions of our hosts and their guest speakers. Views and opinions expressed in the podcast are our own and do not represent that of our places of work. This podcast is for informational purposes only, and content here should not be taken as medical or professional advice. Please consult your healthcare professional for any personal recommendations and medical care. While we make every effort to ensure that the information we are sharing is accurate based on the best available information at the time of recording, we welcome any comments, suggestions or feedback via our website contact form, home.com.au/contact. Names and details of personal experiences may have been changed to allow for anonymity and privacy. To join the conversation, join us on social media at Home Postpartum.